Hi, good afternoon, everyone. I am Gabriel Albornoz, Chair of the Health and Human Services Committee of the Montgomery County Council, and I'm joined by my colleagues to get an update today on healthcare for the uninsured programs here in Montgomery County. We know that too many of our county residents are either or underinsured here in our community, and while Montgomery County has been a leader nationally in this space for a number of years, we recognize there's always more that we can and should be doing. And we are fortunate to have a nationally recognized Department of Health and Human Services and nationally recognized organizations such as Primary Care Coalition among us, and also fortunate that they work so closely together. So with that, I will yield to our incredible team, and then we can begin the presentation.
Thank you, Mr. Albornoz. And we just wanted to provide a little bit of opening context before we get into more detail on these programs with our Department of Health and Human Services. The network of programs that the county supports for individuals experiencing a lack of access to insurance is a really robust and extensive investment that the county makes, and it covers a wide range of specific needs for individuals, as well as providing a primary care avenue for individuals as well. This has been a long-standing program in the county, and because of the number of programs involved, because of their complexity, we really wanted to take this time to have an in-depth discussion of the programs and of really the current state. This is a current state discussion today. All of these programs, though, also there have been such dramatic changes in the healthcare environment, in the environment, after the pandemic, that also we know that there will be discussions about the future of the programs in terms of their structure, their reimbursement rates, and some of their operations. We do not anticipate resolving those questions today. This is really, again, about understanding the current state and positioning the committee to take on that set of decisions, largely beginning in fiscal year 24 budget deliberations and then probably throughout the course of the fiscal year ahead. So just wanted to position that, again, this is really, again, just to understand where we are and then tee up where we're going, and we will look at it a little bit as a conversation in multiple parts, the next part to come back to you again in FY24 budget. So with that, Ms. Clemens-Johnson is going to provide some context overview before we dive in.
Good afternoon, council members. So I'm really just going to go over the staff packet, and then we'll let the HHS go over their very comprehensive presentation. So our healthcare for the uninsured programs have been around for 15 plus years. I always say the limitations of our program are that they are not insurance. They are the safety net, or what we would call the provider of last resort. And the services do not mirror insurance. That does not mean that they aren't good quality and provide excellent and great services. They just cannot provide the same scope of services that an insurance provider does. So the type of services are very comprehensive throughout all the programs, and we're going to talk about all of them. So there's primary care, specialty care, preventative services such as mammography and colonoscopies, medications, behavioral health. There's dental services, both county dental, and there's also dental sites at 2 of the clinics that participate in the program, and navigation services and health education programs like diabetes educations. So the programs are leveraged sometimes with grant funds. PCC and the clinics themselves apply for grants, and they utilize them either, sometimes they work together within a few clinics, sometimes it's for all the clinics, sometimes it's for one clinic and they do it for their patients. So it really just varies across the network. And then some of the clinics also receive grants through the county grants process for specialized things. So I believe one clinic receives a grant to help with like pharmacy services at their clinic to just enhance that for their patients. So I would say the greatest strength of the healthcare for the uninsured programs is the public-private partnership between DHHS, the Primary Care Coalitions, the Health Centers Leadership Council, which is the CEOs or executive directors of the Montgomery Cares clinics, and our hospital partners, such as, all of the hospital partners, and I will call attention to Nexus Montgomery. They aren't part of this discussion, but they definitely have a dotted line to the healthcare for the uninsured programs. Well, more than a dotted line. But I'll say our county health programs, they really were birthed out of the need within the community. I would just call attention to maternity partnership that I think 20 plus years ago Holy Cross Hospital came to the county and they said, hey, we have a number of women who are coming to our hospital and they're delivering without prenatal care. So at that time, the county decided, okay, let's figure this out, and the maternity partnership program was started. So it was initially just a partnership between the county and Holy Cross to make sure those women got prenatal care. But it expanded and it provided other wraparound services, now providing postpartum services. So the programs have always been driven from a place of need and being responded to the needs of our community. So in your packet, you'll also see various data measures that we were able to pull from the programs. So there's information on like patient data trends, encounters, and we also included an addendum with demographic information, which is usually reported on an annual basis or as requested. So it's like race, language spoken, federal poverty level, etc. So, and then there's also not included within this report is that within the programs, they also track quality and performance measures. So the number of annual physicals, the screening rates, diabetic foot exams, and the clinics, they are reviewed quarterly with the Montgomery Cares clinic directors and their quality improvement group. And so they look at those and say, hey, what can we improve? What are our needs? You know, there might be a need for eye exams when they see across the clinics that patients are getting that. So we really have those touch points to be aware of what's going on within the system and what the needs are. So on a monthly basis, the data information, mostly utilization information, is shared with the Montgomery Cares Advisory Board, and they really play that key advisory function for DHHS and the county in general in terms of monitoring those monthly, month-to-month data trends. So those are really essential because it really tells more of the story of what's going on with the programs, because like we talk about Montgomery Cares, but Montgomery Cares is representative of 10, soon to be 9, independent non-profit clinics who all have their same own mission goals and things like that, but they all participate in Montgomery Cares. So sometimes we'll see for the data, like if there's might see a downward trend, but that might mean that a provider was out for a month. And so sometimes it gets down to the very minute details of the story that the data tells. And it's the advisory board that really jumps in and clues in and says, hey, what's going on? Let's raise this to the department, or let's raise this with council and show and be able to tell the story of what's happening and how this is affecting our patients. And then I guess I'll just wrap up to say the packet touches on the FY23 budget additions, some highlights and where those programs are and how they've been able to utilize those dollars, and the current challenges and challenges and things that the programs are facing, just as the provider network. When do you add providers? When providers, like we have a provider leading the network, how does that impact the network? Where are the clinics located? Is it meeting the need? Are there transportation issues? You know, there's tons of things across the provider network that are constantly being reviewed. The reimbursement structure and rates, especially with Montgomery Cares, has always been something that has been came before council. Council over the years has been responsible for setting the reimbursement rate within Montgomery Cares, and that was on a fee-for-service status. So the department and the partners have really, stakeholders I'll say, within the programs have really been looking at the reimbursement rate structure in terms of the healthcare environment. Is it still reasonable to pay fee-for-service rate? Should there be another model that they should pay? Right now, during COVID-19, Montgomery Cares went under a block payment structure just to ensure that the clinics were still being paid during that time of so many changes within COVID and trying to meet the needs of the population. And the other thing is eligibility. So eligibility in terms of this, in terms of the threshold for all of the programs is 250% of FPL or below. And so what we're talking about with eligibility is more of the process. With Montgomery Cares, they're trying to determine what are the next steps for eligibility determination. It used to be centralized within the clinics. Right before COVID, they went to where it was a phased-in approach where OESS was doing some eligibility and others of the clinics were doing eligibility. And during COVID, eligibility was kind of put on hold, if you want to say, and then patients were automatically renewed during that period, which is still currently going on. So that's pretty much it for program updates, and I will hand it back to you, Chair.
Thank you. Let's hear the presentation.
So good afternoon, HHS Chair Albornoz and Council Members Sales and Lutke. Just want to pause for a minute and say we celebrate with you during Women's Her Story Month. And so we celebrate you and your colleagues as we have a discussion today, a transformative discussion on where we'd like to move with our healthcare for the uninsured, looking at a vision that holistically expands access to improve the healthcare of the uninsured and underinsured in Montgomery County across the lifespan in an innovative, person-centered, and well-coordinated system of care. And part of that transformative vision includes developing a process evaluation to determine which programs and which efforts are effective. And so Dr. Rogers and Ms. Graham have a very robust presentation to walk through this afternoon that will highlight some of those transformative ideas, recommendations, as well as provide the data points which speak to the needs of a transformative vision. So I'll stop there with those opening comments. Council Chair Albornoz, Council HHS Chair Albornoz has to say, and turn it over to Dr. Rogers.
Good afternoon. Dr. Christopher Rogers, Policy and Strategy Officer for the record. Good afternoon, HHS Committee Chair, Councilmember Albornoz, and fellow council members. Good to be here today before you to talk about healthcare for the uninsured programs, and want to thank council staff, Ms. Clemens Johnson and Ms. McGuire, for their work. Ms. Clemens Johnson knows these programs very well, having been in DHHS working on these programs for years. We wanted to take the time to provide background, mainly for the new council members, on pre-pandemic outline of the healthcare for the uninsured programs, kind of what's been happening in the programs during the pandemic, and as Dr. Bridges just mentioned, where we would like to go post-pandemic. And while there are many slides, there are some salient points that I will touch on throughout my presentation, and then allow council members to review the presentation at your leisure so that we can move forward with questions. So there are 5 programs that are part of the healthcare for the uninsured system. Each program has its own standards, policies, processes, etc. And so from a departmental perspective, it oftentimes makes it challenging to evaluate the programs. It makes it challenging to monitor coordinated care. It also makes it challenging to monitor and track patients over their lifespan and the different services that they interact. And so the department, along with the county executive's office, we have been really thinking about the importance of having a coordinated system, even perhaps one system where we draw alignment amongst all of the programs. And so when we think about the advantages of a coordinated system, it allows us to ensure that there's cultural and linguistically competence across all of our programs. It allows us to organize our programs in a coordinated and effective way in one network. It allows us to build meaningful partnerships across our programs with our stakeholders, with the families and with the patients as they interact with each one or this one aligned system. It also gives us an opportunity to ensure that the policies and the management infrastructure are coordinated and aligned across a more integrated system. It controls costs. This opportunity allows us to better monitor quality across all of our programs and ensures efficiency in evaluation. Next slide, please. And so what we wanted to do on this slide is show council the HHS committee, the various funding by program. As you can see, there's 5 pots of funding, and what the executive branch has really been thinking about is, what would it look like perhaps to have one pot of funding where we have this coordinated system of care that provides access to multiple different benefits and services for a single individual or single household. Next slide, please. So let's talk about each one of the programs briefly. We'll start with Care for Kids. Next slide, please. This slide here just provides an overview of the various services that are offered within Care for Kids. Again, you'll find many similar services across our healthcare delivery programs. However, again, processes, accesses, how we track outcomes, how we monitor data, all those things are disparate and different across the different programs. And so the importance of standardizing and aligning that is going to be critical as we look to improve health outcomes for our uninsured residents. Next slide, please. So here, and I think the Primary Care Coalition, my partners, for providing us with some data, as you see in these slides. And the one piece I want to emphasize on this particular slide is that there's been great emphasis in the Care for Kids program on the early identification of newcomers. And so we thank County Council for funding and providing the Primary Care Coalition with 2 community health workers that are stationed at Rocking Horse so that we can identify newcomers into the county and we can get them enrolled in health care and also other social care programs that we offer within DHHS and within the county. Next slide, please. CFK offers integrated behavioral health across our provider practices. As you can see on the screen, the various public safety net providers that participate in the Care for Kids program. We also have, for example, Kaiser Permanente, who offers us, I think, somewhere around 700 or 1,000 free slots per year where they see our patients for free. Unfortunately, we do have challenges with being able to collect that data. So any data that you see representative of Care for Kids does not include those 700 or 1,000 children as far as their encounters, their utilization, and things like that. We also leverage voluntary providers across all of our networks. And so sometimes you may or may not see that data incorporated, but we have notes accordingly where that pertains. Next slide, please. And so here you see a trend line of Care for Kids, the number of children that have received services in Care for Kids FY22 compared to FY23. One thing that is important to note is that while enrollments in Care for Kids are high, we roughly have anywhere at the end of a fiscal year somewhere around 7,500 kids enrolling into the program, almost 8,000. Utilization remains below pre-pandemic levels. And so, what we want to really begin to focus on with the Primary Care Coalition is how do we continue to engage patients, continue to engage families so that they can seek care and begin to shift their behavior towards engaging the healthcare system, because we want to make sure that our children are going for their preventive appointments, getting primary care, specialty care, behavioral health, etc., where it's needed. So we always have a high enrollment, but utilization remains low. Next slide, please. Let's talk about dental services, which is another healthcare for the uninsured program. Next slide, please. So here's a slide that provides an overview of the DHHS dental program. The one piece that I'll touch on later that I will point out is Medicaid, that we did start participating in Merrily Healthy Smiles. But again, I'll touch on that in a later slide. Next slide, please. This slide provides an overview of the various dental services that we offer across our 6 dental clinics. Now, one of those dental clinics is currently closed for renovation. That is our Colesville location in East County. However, we do have the 5 clinical locations open that are spread out throughout Montgomery County that are offering these various dental services to our residents, both uninsured and Medicaid. Now, we don't distinguish between what services we do or do not offer for Medicaid, because the capabilities to offer for example, crowns to the uninsured population, we want to make sure we offer those services as well to the Medicaid population. If there's a service that we do not provide, we will refer out, for example, to one of the local university dental schools like the University of Maryland School of Dentistry or Howard University School of Dentistry, where we continue to increase collaboration and partnerships with those. I'll talk about some of the other efforts to engage community safety net providers across the county as well in dental care. Next slide, please. DHHS, we did strategically realign dental services in September 2022. County Dental Services moved to Public Health Services Community and Population Health Division. Now, on your screen, you see several reasons for why we made this strategic realignment into community and population health. One that I'll just point out is that second line there, which is places a greater focus on integrated medical and dental services in different healthcare and public health settings. So we know research has established the association between oral health care and somatic health care, how one's ability to care for their oral health and their oral health conditions impacts that care. So we want to make sure that we are integrating both of those services into one setting. And so that allows, for example, myself and our dental director, Dr. Boyce, to work closely together to ensure medical and dental are integrated. Next slide, please. Again, just some data on county dental FY21 to FY23 patient visits over the past few fiscal years. Next slide, please. Again, another slide here that shows FY21 to FY23 patients served. We do see that we are pretty much around the levels that we were this time in January FY22 and January FY21. Again, across all the services, for example, the Montgomery Cares, we are beginning to see more patients engage the dental system, so that as utilization begins to increase, we'll continue to monitor that. Next slide, please. I mentioned earlier about DHHS's efforts to begin participating in Maryland Healthy Smiles. As we all probably know, January 1st, 2023, the state of Maryland expanded dental benefits to Medicaid recipients, and the department thought it was important that the county begin to accept Medicaid. There is a significant shortage of Medicaid dental providers in the county, and so we wanted to see how we could begin to help fill that gap in some capacity. We are currently participating at the lowest level, which is seeing new emergencies only. And this is because we want to really evaluate our capacity to continue to see our county uninsured residents as well as our Medicaid recipients. As we continue to evaluate that over the next several months, we'll begin to scale up into another level of capacity, which is perhaps seeing all Medicaid recipients and starting in 2024. We are noticing that a portion of our patients are in fact eligible for Medicaid, for dental benefits under Medicaid. For example, in our senior dental program, we may have dual eligible individuals who did not have that dental benefit, but because they are Medicaid recipients, they are now beginning to experience and receive that benefit. And so while we are only open to emergencies only for new patients, we will continue to serve any of our existing patients who have full Medicaid benefits. Next slide, please. Let's talk a little bit about healthcare for the homeless. Next slide, please. Healthcare for the homeless, as you can see, offers these 6 different types of services. We have medical support and shelter, medical support and housing, medical and dental and psychiatry. And I'll emphasize this point a little bit later about the important integration of medical, dental, and behavioral health across this coordinated alliance system that the executive branch is looking to establish in the near future. Next slide, please. This is a slide that provides, again, another program overview of the Healthcare for the Homeless program. And I'm going to move forward through these next couple slides that council can read at their leisure, and want to jump down to the data for Healthcare for the Homeless. As you can see, we are seeing a significant spike in the number of patient visits in our Healthcare for the Homeless program. And this is also the next slide, please. And this is because we are beginning to see, as you probably well know, an increase in the number of individuals homeless across the county. And so because we're seeing that increase in the number of individuals who are homeless and that are receiving services in our shelters, we're seeing that a simultaneous effect in our healthcare for the homeless program, where they provide primary care, behavioral health services within our shelters, and that those residents also have access to dental services within our dental clinic, as well as within the community at a contracted provider. Next slide, please. As Ms. Clemens Johnson mentioned, next slide, please. Maternity Partnership Program. The Maternity Partnership Program provides access to prenatal care, delivery care, and post-delivery care for uninsured mothers and their children within the Healthcare for the Uninsured networking program. You see that our partners on the screen that participate in the Maternity Partnership Program. Again, this is a public-private partnership. I think one thing is to emphasize is that home-based case management, ensuring that our families or our mothers have someone to visit their home to provide navigation services, to provide health promotion, provide that culturally and linguistically competent, coordinated care and assistance as our mothers and their children begin to navigate the system. Next slide, please. One thing I wanted to pause here, and which I don't have a slide, is the Healthy Babies Equity Act. As you all are probably aware, the Healthy Babies Equity Act, it's set to go into effect on July 1st, 2023. The team at DHHS, we continue to engage with the Maryland Department of Health about that start date. That start date may be a little bit up in the air, but we are still planning for July 1st implementation of the Healthy Babies Equity Act. Now, the department anticipates that probably somewhere around 70% of our current maternity partnership patients will be eligible for services under the Healthy Babies Equity Act. Because that act goes into effect at the beginning of the fiscal year, we'll continue to monitor our enrollment levels in the maternity partnership program over FY24 to really understand the true impact of our enrollment numbers as we segue into FY25. Next slide, please. Montgomery Cares. Let's talk a little bit about Montgomery Cares. So here are the various services that Montgomery Cares offers. Again, emphasis on integrated medical, dental, and behavioral health care is kind of the driving theme across all of our health care for the uninsured programs. Next slide, please. Some data, again, provided by PCC. Thank them for the data that they have. You see fiscal year 2022 data for Montgomery Cares. We served approximately 22,000 residents. We also had telehealth encounters. Telehealth encounters currently range about less than 10% of all encounters across our clinics. We continue to provide them with the flexibility that the individual providers deem necessary to determine whether or not a patient wants to be seen in person or telehealth. That's kind of consistent with what we're seeing across the industry, is that many patients are wanting to come in person to engage their care provider, but some also do like the flexibility of having telehealth. So we're experiencing those same trends within the Montgomery Cares network as well. Next slide, please. Now, this is an overall utilization of Montgomery Cares FY 2005 to FY 2022. One thing that I'll mention is that uninsured adults were more likely to delay or forgo care during the COVID-19 pandemic because of costs and because of reductions in employment. And what we are beginning to see is that as the labor market again begins to recover for our healthcare providers, our clinics are beginning to be able to hire practitioners, as well as patients are beginning to re-engage the healthcare system. We are beginning to see an increase in our utilization in Montgomery Cares. In fact, between January 2023, we saw a 23% increase in patients and 24% increase in encounters compared to January 2022. And so, again, we are beginning to see patients re-engage the healthcare system, as well as providers beginning to able to overcome some of those labor market challenges, such as hiring nurse practitioners, getting volunteer providers that they count on within the Montgomery care system. Next slide, please. Ms. Clemens Johnson mentioned a little bit about reimbursement. In FY23, the department assured the council that we would stand up a reimbursement work group for Montgomery Cares, and we did just that. And so in August through September 2022, the department, along with the clinic executive directors, county council staff, Montgomery Cares Advisory Board, and the Primary Care Coalition, we implemented a work group to develop and endorse a proposal for Montgomery Cares primary care rate that supports the deliverables and expectations for a patient-centered healthcare and related services delivered by participating safety net clinics and health centers. What you see on the screen is the work group's recommendation. That the work group recommended that in FY24, Montgomery Cares has a reimbursement rate of $175 per encounter, which reflects about 70% of the average cost of care. Now, some considerations that the clinics had during those conversations that influence or impact that rate, things such as case management and care coordination, things such as addressing the social determinants of health that many of our uninsured residents have, medication dispensing, imaging, all of these additional services that we ask or that the providers do voluntarily, that rate is reflective of 70% of that particular cost. Now, the executive branch has not made any decisions regarding the FY24 rate at this time. Next slide, please. Let's look at, in closing, some combined data for the county health programs as well as HHS. And what's important to note is the emphasis that the department places on health equity. That is ensuring that everyone has equal access, fair and just opportunity to reach their highest level of overall health and well-being. As you see on the screen, the department primarily sees the what we call minority majority population within the county. Significant overwhelming portion of the residents that we provide services for in HHS are either Hispanic, non-Hispanic, Black, Asian, American descent, or of multi-race. Next slide, please. Now, utilizing the social vulnerability index, what we wanted to show is where areas within the county had high social vulnerability and the impact that the county health care for the uninsured programs are having by doing outreach to those clients. And so on these graphical displays, you can see that our county health care for the uninsured programs, we are reaching clients within zip codes that have high social vulnerability. As you can see on the graphical display is that roughly almost 85% of the patients who receive services from the healthcare for the uninsured of Hispanic and Latino descent. And you can see the concentration across our various zip codes where there's social vulnerability, where we are seeing patients engage the system, and where our partners such as the Primary Care Coalition and other stakeholders are reaching out to patients to get them engaged in care. Next slide, please. Similarly, we have a kind of heat map that displays social vulnerability index across zip codes and where our clients ages 0 to 12 are engaging with our county health care for the uninsured programs. Next slide, please. Likewise, we have one for our adolescents ages 13 to 18. We kind of see then at 209, I think that's really 06 or 05 area, where there's a high concentration of individuals ages 13 to 18 that are participating in our county health care for the uninsured programs. And that area also has high social vulnerability. And so that's what we want. We want to be able to engage individuals and residents in that zip code, in those zip codes. Next slide, please. Similarly, in adults, we see it really mid-county East County. We also see some Silver Spring area, where those areas we know in the county that have high social vulnerability, individuals who are aged 19 years and older are engaged in our system. Now, this is not to say there's more work to be done to ensure that we are enrolling residents who are eligible into our county health care for the uninsured programs and ensuring that they are getting out for their patient visits, dental care, as well as behavioral health. Next slide, please. Again, how HHS really focuses and targets our services on equity focus areas is really what this particular graph speaks to. Let me go on to the next slide as we talk about, as Dr. Bridges mentioned, our overarching strategic policy and program vision and framework. The importance piece here is that if we are to continue to achieve and strive towards health equity in the county, we must continue to evaluate and improve and transform our systems and our policies. Especially begin to look at those systems and policies that perhaps have resulted in generational injustices that give rise to racial and ethnic health disparities. We want to continue to see how we can address those in a collaborative way with council, with our community stakeholders, as well as with residents as we listen to their voices about their needs, their preferences, and their desires. Next slide, please. So Dr. Bridges talked about this transformative vision that the executive branch is embarking upon as we move forward, kind of the post-pandemic into an endemic state of COVID-19. And I'm not going to take time to read that, but what I will say is that this emphasis on person-centered care. You know, we're moving away from this idea of patient-centered care to person-centered care, because when we talk about patient-centered care, we sometimes it has a connotation of isolating the individual to a disease state or to an illness. And so when we think about patient, we think about someone who is sick. But when we talk about person-centered, we really are placing an emphasis on the person's overall well-being, their social needs, their mental health, as well as their somatic health and their oral health. So we really want to focus on person-centered care. Next slide, please. Now, this framework is the guiding policies and principles for the future of the county healthcare safety net program. I'll talk about these briefly. Integrated medical, dental, and behavioral health. Well, I've been emphasizing that all along. Align and standardize programs to improve wellness. I talked about the importance of the executive branch really looking at how do we begin to align all of our programs into one system so that we can drive population health, so that we can evaluate health outcomes and costs, so that we can expand partnerships by identifying new providers to enter into the system, leveraging and improving and growing existing resources as we continue to, as community partners continue to identify opportunities to provide health care delivery for certain targeted populations. We should be looking at existing resources, existing programs that we have in the county, and seeing how we can integrate these new initiatives into these existing initiatives so that we can strengthen and make these new initiatives more robust. Because perhaps the need for this new initiative is that there's a gap in this system. And so let's all come together. Let's address this gap by leveraging and improving and growing on existing resources. Payment parity. As additional community stakeholders approach the county about offering healthcare delivery services for certain target population, we are beginning to see that there's disparities in reimbursement. And so we may be paying one provider $200 and $20 over here for delivering primary care services. We may be paying another provider $140 over here to deliver primary care services. And we may be providing the entire Montgomery Cares network $76.50 to deliver primary care services, all for the same CPT codes. So how do we begin to ensure that there's payment parity across all our providers so that the county pays one rate to all of our providers to deliver healthcare delivery services and standardize it in that way. And again, I've talked about the importance of a coordinated system of care and the challenges that overcomes when we do have that type of system. Next slide, please. I'll begin to wrap up over these next couple slides. Dental, what I will just emphasize on this dental slide is that the dental collaborative work will be using a multi-partner collaborative design meetings where we'll be bringing stakeholders throughout the county who are interested, invested in oral health care for our safety net population. And we'll be looking at things such as quality measurement and dentistry. We'll be evaluating the importance of dental homes, the importance of coordinated and integrated primary care and oral health care, process and referral protocols. How do we refer patients who are in need of services? If there's a wait list, for example, at one provider, how do we then refer that patient to another provider who has openings so that we can ensure that that patient is able to get timely care? And lastly, a dental learning collaborative. We will also discuss the importance of that and the role that that plays. And so the outcome of this dental collaborative will be a report that we'll issue to county council as well as the executive branch that will inform future policy and funding opportunities. Next slide, please. Some other quick items that I wanted to discuss on, and Ms. Clemens Johnson touched on this earlier, but the department is really much focused on a clear and coherent eligibility and enrollment system that includes integrated and seamless application assistance and eligibility determination processes and policies. In essence, our focus is really on real-time point of care eligibility determination. And so that if an individual walks into a clinic, walks into a DHHS office, walks into a community-based organization and says that I would like to apply and enroll into the county's health care coverage benefit program for uninsured, that they will receive that application assistance and they will receive that eligibility determination right then and there so that they are able to begin to engage the system and receive care. We want to make sure that people have access to the right health care benefit program that meets the family needs at the right time, real time. Next slide, please. Montgomery Cares Network evaluation. So we are embarking upon an evaluation in partnership with PCC to really assess the adequacy of the Montgomery Cares Network. And so we want to look at the gaps in the network, we want to look at the challenges in the network, and we want to begin to understand how do we fill and address those gaps. We're going to be looking at things such as availability, whether the provider networks are sufficient to meet the needs of the Montgomery Cares patients. We want to look at the things such as the types of providers that we have within the Montgomery Cares networks, the types of appointments that we're offering, whether or not we're offering those appointments timely. We want to look at accessibility, whether or not the provider's ability to communicate in non-English languages and in sign language. We want to look at things such as accommodation, the provider's operating hours, their appointment policies. We want to look at the ability for our patients to able to realize access to care. We talk about access to care, but are they actually realizing access to care? And acceptability, whether our providers are pleased with the characteristics of our providers, their age, their gender, their sexual orientation, their social class, the race and ethnicity of our providers. All of these questions will be answered in this network evaluation, adequacy evaluation. Last couple slides. The executive branch is very committed to expanding access to care through increased community provider partnerships. So there are ongoing efforts to identify new primary care providers to add to the Montgomery Cares network, even perhaps this fiscal year. And so we want to make sure that we are expanding the network right now while we continue to do this evaluation, because we are hearing from the community, both stakeholders and residents and council, the need to add additional providers to our Montgomery Cares network. And again, that's just there's a subset of our residents in the county who are not eligible for our county health care for the uninsured programs, but are unable to afford health care coverage from the Maryland Health Benefit Exchange or qualified health plan. And so the department and the executive branch are very much interested in ensuring that those subset of individuals also have access to health care. And what are policies and programs that we can design and implement, engage council around to begin to address that gap? We kind of think of that donut hole. So we have individuals that can go sign up for a qualified health plan, but they are stating to us that I cannot afford it, but yet they are not eligible for our health care for the uninsured programs. How can we as a county support those residents as well so we can ensure that all of our residents have access to care? I'll stop there, and we welcome County Council's questions.
Well, you can come up for air now. That was really a lot of information and presented in a very effective and impressive way. I did have a few questions. So, Montgomery Cares, and I'm happy to hear that the county executive is considering, or at least having a conversation about the reimbursement rate. Do we know when the last time was we adjusted that reimbursement rate?
The last time we adjusted, I believe, was FY19, if my recollection is correct.
That's helpful. That is some of the feedback I've heard from some of the providers, particularly in the dental space, that's missed opportunity, and they'd be able to do more if that reimbursement rate were higher. So I know obviously there are a lot of challenges, but this is a key infrastructure issue. And serendipitously this morning we had a joint Education and Culture and Health and Human Services session on the wellness programs and the needs that we're seeing across different communities. And one issue that is recurring is behavioral health and more clinical referrals to students that are brave enough to come forward, and of course we want to support them and their families. But then that handoff, that referral to clinical care is sometimes challenged by the inability of the family to be able to seek health insurance coverage. Could we just briefly spend a couple of moments talking about that and any potential gaps in the system there that we want to take a look at long term? And Dr. Rogers or Dr. Bridgers or Ms. Graham, whoever feels comfortable responding, please do so. Thank you.
Care for Kids perspective.
Hi, Leslie Graham, President and CEO of Primary Care Coalition. So I think you're talking about children in the school system.
Correct.
Who are being identified.
Yep.
And so some of those children are insured, and some are uninsured. The majority of the uninsured would be a part of Care for Kids program, and because Montgomery County, because the state of Maryland does have a pretty broad Maryland's Children Health Insurance Program, or Maryland Medicaid for Children, most children who are low income and have documentation status are able to be on Maryland Medicaid. So in terms of the behavioral health, in the school system there are multiple avenues for them to be referred. One is we have, in the school system, you already have linkages to learning, and programs like Linkages to Learning that provide services for the children who are identified in the school system. And then if they are part of the Care for Kids program, they have access to behavioral health services. Thank you to the County Council, which added funding for that. PCC obtained a grant from federal SAMHSA, the agency, back in, I want to say, 2018 or 19, to do a pilot, because prior to that, Care for Kids had absolutely no access to behavioral health services. And so we were able to do a pilot showing the need and showing how we could develop those linkages within the Care for Kids providers, as well as external to the Care for Kids providers. For example, we have contracts for substance use disorder that is in children that can't be delivered in the clinics, or higher level services. And so Care for Kids is able to provide those services, and that after doing that pilot with SAMHSA, the county council was recognized the data and added that to the base budget of Care for Kids. So there is a budget for behavioral health services and Care for Kids. It is on an integrated model so that the children who are served in the community-based Care for Kids primary care providers have access directly in their clinic to integrated behavioral health services for things that are eligible to be managed at the primary care level, and then referrals out, as we said, to higher level services, whether that's through county-based services or substance use services that we have contracts with. In the and about the children who are in Kaiser under Care for Kids have access to behavioral health services through Kaiser. The children who are in the school-based health centers who are part of Care for Kids but are having their primary care managed in the school-based health centers, they have what is available through the school-based health centers and also access to the higher level services such as substance use treatment. But otherwise they are within what is available through the school system. Mm-hmm. So is that the area, Council President, that you are most concerned about when you've heard items such as the children who are being served in primary care in the school-based health centers?
It is. It's not the only concern, but it's just been so highlighted across the board, and it's been presented, and it is a systemic issue, and one that not having sufficient health insurance is seen as a barrier for families in being able to access behavioral health. The good news is we capture some of the students through our wellness programs, but they're not in every school yet. We're working hard on making that adjustment, and that doesn't capture the entire universe of students that are out there. So that's an area I'd like to explore further, and I'm familiar with the additional funding we placed in the budget a couple of years ago, seeing what was on the horizon, but I think it'd be worth reevaluating given where we are now and the needs that we're seeing, which have reached crisis levels.
Sure, yeah, and we do have contracts for students who are being served in the school-based health and wellness centers, Care for Kids children who are being served there as their primary care home. We do have some contracts with existing providers in the school system for behavioral health. So they do have access to services. I don't think we have data on what the percentages who are accessing, whether there's a difference in Care for Kids children based on which of those, whether they are in community practices, pediatric practices, or in school-based, as to whether there's a difference in how many are accessing behavioral health services. We did do focus groups with families to look at what are their barriers to accessing, so we do have that data. I'm just going to ask Hillary that question. Do we have that data, Hillary?
Not segmented, but we might be able to run it.
Okay. Yes, so Hillary says we don't have it right here segmented by their primary care home model, whether they're school-based or whether it is community-based. But we can look to see if we can run that and get something back
That'd be
to
great.
council. And then we could look at, and I think it's also important to take what we learned in the focus groups of students and their families in terms of what they are finding as the barriers to accessing behavioral health care. It isn't just availability, and it is also cultural, it is stigma, it is time for parents to either drive children or be with children. So there are a number of things that we determined during the focus groups as well.
I know. Councilmember Lukey has a follow-up. I have a feeling I know what it is.
You might not.
Yeah, maybe
you might not. You might not. So every school system is required to have a behavioral health services coordinator, and that behavioral health services coordinator is responsible for making sure that the students in the K-12 schools who exhibit behaviors of concern are provided with wraparound services as needed, referred out for different services. And so, one of the things that I have heard in my prior work around the state, regardless of whether you're talking about Montgomery County or Queen Anne's County, is that even if a person has insurance, that the child and the parent, they may be insured, but that does not mean that they are getting the services, because a lot of the providers don't take the insurance, and they're not required to. And I know that's something that, constituents raise as a concern when they say, I need care, or my child needs care, and I'm overwhelmed, and I don't have the wherewithal to submit these claim forms, and so on and so forth. So there's all these other obstacles to obtaining the care that are above and beyond the high need and high demand for service. With the not enough providers to go around and insurance gaps, we have this other hurdle there where we might be able to marry a patient and a clinician, but we can't get it to work right financially because of the logistics of getting it paid for and the reimbursement for the insurance. And I wanted to know if you had, any thoughts about that, or how to better facilitate that.
Well, you're correct, and thank you for that question. I think the challenges that you just underscored and the responses from Ms. Graham for the department kind of just emphasizes this need to leverage resources. For example, one of our programs may be excellent at addressing those challenges, but how do we provide that same level of service and access to a program where that's still a challenge? And so how can we ensure that everyone has access to these same services? One thing that Dr. Bridges has been really driving home to DHHS as the acting director, and it fits within these kind of guiding policies for the future healthcare for the uninsured, is a hub and spoke model.
Right.
How are we maximizing the concept of a hub and spoke model within this transformative vision that the department and the executive branch is undertaking to really address those challenges? And so we are actively looking at this and identifying strategies internally, and will be with our stakeholders as well as council to get input and ideas on how do we address similar challenges that you are mentioning and other challenges that we know exist in this kind of referral care management navigation type of challenges.
Right, and you did say, at the outset, this was a patient-centered model, right? And that's true when you're looking at it through the patient lens, as opposed to, well, this happens over here, but if you check these 3 boxes, and then you can get this over here, but that's not very patient-centered. And so I appreciate all the effort that you're putting into this. You talked about eligibility and this gap where we have folks who are eligible for Medicaid services, and then folks who still aren't able to afford buying coverage through the Maryland Health Benefits Exchange. What is that gap? What is that range and gap for, you're not eligible for Medicaid, but you're saying you can't procure your insurance through the benefits exchange?
Prior to me coming to the county in 2020, I believe DHHS did some analysis to really look at, what percentage of our Montgomery CARES recipients are in fact eligible for a qualified health plan. And we forecasted roughly about 20% of the individuals enrolled in our Montgomery CARES are in fact eligible for a QHP. And so we want to, as I mentioned earlier, the executive branch is really interested in, what type of, and working with council, what type of support can we as a county provide to these individuals so that they can get the right coverage at the right time, because that's more comprehensive coverage.
Right.
That's coverage that'll provide you with benefits for a hospital stay. And we would like to make sure that we're drawing down all of our federal and state resources to ensure that our residents have access to the most comprehensive care before leveraging, county-funded health programs.
And then you mentioned the Healthy Babies Equity Act, which actually went into effect on July 1st of 2022. So you said the effective date was still up in the air. Could you clarify that?
Yes, the state had to delay the implementation of the Healthy Babies Equity Act. While it may have been enrolled at the state level, the state, our understanding is that the state needed to go to CMS in order to get a waiver.
They did need to get a waiver
in order to implement. And so our understanding is that the state is still working through that process and the details. and also the processes and the procedures that come along with
Gotcha.
ensuring those individuals have access to Medicaid and able to communicate that information back to local health departments, providers, et cetera.
Right, so you're saying CMMS has not made its determination yet, therefore it can't be implemented in the local health departments because they're still working out the waiver.
I can't say that piece with confidence, but I know that the state is still working out the
Right.
details on implementation before patients begin to realize that benefit.
Gotcha. Okay, thank you. Thank you so much.
Thank you. Councilmember Sales.
Thank you, Chairman Albornoz, and thank you to all of our panelists for your presentation and the packet that was put together. Just a few questions I wanted to follow up with. I know that there is going to be a subsequent report in November, so I'll keep my questions brief. With regards to the applications for the programs, are the applications provided in different languages?
Yes, the county healthcare for the uninsured applications are provided in different languages.
Okay, and can undocumented residents apply for all these programs?
Yes, that is correct.
Okay, and I wanted to point out, I cannot recall the page, about the maternity partnership program. It seems, I see that, what was it, 1,362 participants identify as white, with only 82 participants identifying as black. Knowing the black maternal mortality rates and black infant mortality rates being the highest among all of the demographics, how are we targeting participants for these programs?
Yes, thank you
Page
for that
50.
question. I think the best way to answer that is the makeup of our uninsured residents in the county. Because our county health programs are primarily serving uninsured residents, we know from the data that many of our residents who are uninsured, it's because of perhaps their documentation status or their legal status. And so, for example, in order to receive Medicaid, if they are newcomers to the United States, they have to meet that 5-year bar. So they have to wait those 5 years in order to enroll into Medicaid. And so we have a significant portion, as I showed on the data slide, of our residents who are enrolling to healthcare for the uninsured programs that are of Hispanic and Latino descent, who we know from the data are more likely to have that undocumented status. And so, whereas black African American residents, while they may be uninsured, one of the primary reasons is not because of their legal status. There may be other factors and there may be other factors outside of their ability to access or be eligible for private insurance or qualified health plan or Medicaid. And so another key eligibility criteria for our county health care for the uninsured programs is that you cannot be eligible for private insurance, Medicaid, or qualified health plan. And so if someone is eligible for those services, they will not be eligible for county health care for the uninsured programs. However, we do continue to make sure that we engage, as we showed that social vulnerability index geographical. We do continue to make sure that DHHS, along with our partners, are conducting outreach to those zip codes that we know are most impacted by high social vulnerability, which includes access or lack of access to health care.
And Councilmember Sales, just looking at my notes here, in listening to Dr. Rogers' response, this is definitely a space where we need to have ongoing conversations, looking at the data to where our maternal and child health program could really look at our Babies Born Healthy initiative and look at strategic measures to increase enrollment I know that we did this during COVID. We did it through media campaigns. We did it through public service announcements. And so this is a space, in listening to your question, that we need to revisit to increase enrollment and to look at those, look at our African American mothers who need maternal and child support. So I did make a note of that, but I thought that in listening to you, that's a space of consideration, since this is a work session.
Yeah.
This is a space to consider an increase and expansion of that.
Because I thought we had a maternal health initiative for women of color, specifically Black women in the county. We do have one. Okay. Go ahead.
And that would be, I believe, and correct me if I'm wrong, but that program would be separate in terms of not being captured here. So I
Yes.
think that is one, sort of speaking a little bit to some of the coordination issues that the department was flagging. Excuse me, you're seeing the data there for this specific program, and you're correct, there is one also under the African American Health Initiative program.
Okay. All right.
So again, Councilmember Sells, this is a space where we've taken a step back and we're looking at across our programs, and we've been actively listening in these sessions where we talk about a holistic approach. And within HHS, we need to look at all the programs and the connectors across the access points, the race and ethnicity points. We have many programs, but they may be siloed or segmented. Now, this is a space transitioning from a pandemic state to an endemic state to realistically assess. I know Councilmember Albanos had conversations pre-COVID about the backlog of dental clients that we had, and so we took a robust look at increasing access, and so we realigned that program. And so as we continue these conversations and we really take a closer look at our program and our configuration and our access points, this is where we need to look across HHS to look at those various touch points to either consolidate or increase, which goes back to one of Dr. Rogers' previous slides, and looking at expanding our Montgomery Cares network. So we have work to do.
Yeah.
And so this is a space as we continue to listen and work with council.
And also looking at this, the usage rate, it may be helpful to think about how are we raising awareness and conducting outreach to ensure that people not only know about the program, but know about the targeted interventions that we have, but understand how easily they can access these resources. I know that there are hundreds of unstaffed positions across HHS, and wanted to know if you wanted to speak about that with regards to how that would influence or improve program outcomes, if that has any correlation to improving outreach.
Yes, Councilmember Sells, we're trying to determine who can provide the best the best answer, but the answer is yes. We recognize the vacancies, and we've been working very hard in the recruitment space, our senior human resource manager, and we've been working with the Office of Human Resources to look at those particular vacancies in those categories realistically. But we need more staff, and we're working on getting more staff. And the recruitment strategies, we've been working with the universities, we've been partnering with community stakeholders, looking at pipelines of resources. We've even begun to have conversations about internships in the agencies to create a pipeline for when they, get to college, they can get a sense of real-time health and human service work. And so that may be a good piece and leverage piece for them to transition into the health and human services space.
Yeah.
So we've examined all of that. The vacancies are key, and the less vacancies we have, the more we will be able to do outreach. Dr. Rogers, you want to add to that?
Yeah, I would just say this kind of goes to the point of aligning the system, because as the healthcare for the uninsured programs, they grow rapidly. I mean, each fiscal year we're adding different components, and the HHS staff, I think you all asked questions about how many staff we have working on Montgomery Kids Care for Kids. We're not growing as fast as these programs are growing. So the ability to keep up and to track and to monitor these new initiatives that our stakeholders are asking for is very challenging. And so aligning and integrating and pooling resources so that we can more effectively evaluate, partner, collaborate, grow, and improve is very critical to our post-pandemic endemic as we continue to look at and evaluate our healthcare for the uninsured program. So I appreciate that question. Thank you.
And I know that public-private partnerships always result in great outcomes with our students with MCPS. In Montgomery College in preparing the workforce of tomorrow, we've had quite a few work sessions to talk about, preparing the workforce of tomorrow. And if we're thinking about how to fill these vacancies, let's think about some of the programs that exist within MCPS and how we're trying to strengthen that pipeline from now and not just at the college level. Speaking of the college level, I attended the universities at Shady Grove, their new biomedical center, and they have a dental clinic that I had no idea about. I wanted to know how we are raising awareness about that clinic and how we're getting that information out to our residents as a third option.
So from my vantage point, I'll let Dr. Bridges, as the director of HHS, answer. At my level, that's new information for me, but I have notated that as a follow-up. Happy if your office has a point of contact there that would like to place the department in contact with, happy to make an outreach to that individual so that myself, dental director, perhaps even Dr. Bridges and Dr. Davis, we can have a call with them so that we can understand how we can better partner with them.
Okay.
So, Councilmember Sells, thank you for that information. We now have another contact point. I was not aware of that, but that's what these sessions are for.
Yeah.
I also wanted to share that we have a meeting on Tuesday with Washington Adventist University to look at potential sources, resources in Tacoma Park and through that area. So we are doing our due diligence and outreach, and we understand that it takes time, but we have to progressively begin now to get there. So that's what we're doing. So any information, we appreciate the council's sharing, and we will follow up and have a referral. The other point with the referral is Dr. Rogers talked about specialty care docs, and so we have a challenge with recruiting specialty care doctors and dentists, and so we are actively pursuing that as well with all of the universities, as well as any telehealth specialty providers and clinicians. So we are really taking a deeper dive and looking at what those needs are. Again, COVID taught us a lot.
Yeah.
And so we're looking at those lessons learned through COVID, looking at those clinical and those programmatic challenges that are on the horizon or before us now. So
Good. And because we are approaching budget season, I believe it was this week or last week, the county executive rolled out a $20,000 bonus for the recruitment of police officers. And so if there are some creative ways to recruit the workforce of tomorrow in our healthcare space, given the increasing needs of our diverse residents, please, we look forward to hearing about those. Thank you, Mr. Chair. I yield.
Thank you. Good questions, good comments. So just wrapping up, a couple other thoughts. The integrated approach is long overdue, and obviously we saw firsthand why that's so important over these last few years. And the notion of expanding our provider base is also important, but I also think there's capacity within our existing providers to expand their base of services as well. And one of dozens, if not hundreds of examples, the Mary Center. They have a dental clinic which is extraordinarily successful. Dr. Davis and I are going to go out and check it out soon. They have space within their existing building, so that they can expand almost double their services if the county meets them part of the way. And there are many other examples, and I really love what we're doing to get us closer to residents. Dr. Peralta, and I really want to thank HHS once again for working on expanding that opportunity, which I know is so important, especially right now, because the needs are growing across the board. We haven't really discussed very much our aging population, but that continues to be the fastest growing demographic we have here in the county, and there are clearly gaps in service. And to the degree to which we can streamline the bureaucracy and make it easier for county residents, I really like that slide that you had and the recommendations at the end, those points of entry. And the last thing I'll say for now is we have to make sure that the customer service for the people that, and the clients and the patients that come to our various facilities receive the best information, that it's done in a culturally humble way. So that they can then spread the news among their community, because they are often the best promoters of these wonderful programs and services. They tell their friends, they tell their neighbors, and they can go much further than we can within our communities. But I thank you for the very comprehensive presentation this afternoon. I know that there's still a lot more work to do, and we look forward to working with you through the budget process. But I also want to thank staff. This was a very good way for us as a newly formed committee to have some baseline and context when we receive budget information from the executive. This will give us more time to be able to dive in. So thank you all very much. And with that, we are adjourned.